예, 제 1회 코리안 DC&R 디스커션 포럼에 참석해 주셔서 감사합니다. 저는 서울 아산병원 박인자입니다. 오늘 모더레이터를 맡겠습니다. Hello everyone, and thank you for joining us at the first Korean DC&R discussion forum. I'm Inja Park from Asan Medical Center. I'll be your moderator today. 이 세션 45분간 진행이 될 예정입니다. 핸드폰은 무음으로 해주시면 감사하겠고요. 다음 오디언스 디스커션 타임이 되면 모두 화면에 얼굴이 보이도록 해주시면 더욱 감사하겠습니다. 이 영상은 녹화를 해서 DCR 유튜브에 게시가 되니 참고해 주시기를 부탁드립니다. 원활한 그 디스커션을 위해서 질문은 한국어로 해주시기를 권장드리고요. 자유롭게 사용해 주시면 됩니다. 직접적인 디스커션을 위해서 영어로 질문을 하시고 싶으신 경우는 영어로 질문을 해주시고 한국말로 간단하게 번역을 해주시면 감사하겠습니다. 해외 저자 중에서 이제 질의를 해오신 분이 있어서 저희가 영어로 가이드라인을 적었고요. 네네. 저희가 이게 1회 코리안 디스커션 포럼이다 보니까 굉장히 이제 의미 있는 행사입니다. 그래서 이 행사에 대해서 인트로덕션을 해주시기 위해서 DCR의 편집장이신 수잔 갈란딕 선생님이 직접 참석을 해주셨습니다. We are fortunate to have Sujan Galandik, the editor-in-chief of DCR, with us today. And to kick things up, start smoothly. And Sujan, thank you, Sujan. Sujan, could you give the introductory remarks for us?
Well, yes, thank you very much, Professor Park. Well, I'm delighted to welcome you to the first DCR Annals of Coloproctology Discussion Forum. And I'm particularly pleased that both Professor Kim, who is a past president of the Korean Society of Coloproctology, as well as Professor Kang, who's the current chairman of the board of the society, are both participating on the panel today. And both Professor Park, editor of Annals, and I are so pleased to be able to host this session today. And our special guest today, Professor Perez, is the current section editor of international content for diseases of the colon and rectum. And I thank you very much for joining us today. And I hope that this is going to be just the start of many very interesting sessions. Thank you.
네, 저희 미리 공지드린 대로 와치앤웨이트 후에 로컬 리그로스가 발생한 환자에 있어서 디스턴트 메타스타시스의 위험성과 그 적절한 컨트롤 그룹을 어떻게 설정하는 것이 좋은지에 대해서 저자인 닥터 로드리고 파레즈와 함께 디스커션 해보는 시간을 갖도록 하겠습니다. 저희가 오늘 네 분의 패널리스트, 한 번에 이렇게 모시기 어려운 네 분의 패널리스트를 함께 모셨고요. 특별히 김영일 선생께서 통역으로 수고를 해주시도록 하겠습니다. We will talk about the announced topic with author Dr. Rodrigo Perez, and we have four panelists today, Dr. Namgyu Kim, Songbom Kang, Kyungmo Son, and Suyong Lee. And to ensure that everything runs smoothly, Dr. Young-il Kim kindly will serving as the interpreter today. And, 그리고 로드리고 파레스에 대해서는 굉장히 다들 잘 아실 거라고 생각을 합니다만, 와치앤웨이트를 처음으로 주장해 주셨던 안젤리타 하버감과 함께 일을 쭉 해오시고 계십니다. 그리고 와치앤웨이트에 대해서 굉장히 실험적인 것 그리고 프랙티컬한 것에 대해서 연구를 계속 해오고 발표를 해오고 계시고요. 이 와치앤웨이트 분야에 대해서는 가히 이제 오피니언 리더라고 할 수가 있겠습니다. Okay, Dr. Perez, I already have given brief introduction of you, and I believe most people here will know you. But if you don't mind, would you give sharing a few words or say hello to Korean participants?
Absolutely. First of all, thank you, Professor Park, for the kind invitation to speak. Susan, for allowing this to happen, and for me to present our work here today. It's a pleasure to be among so many Korean friends. And I will try to speak slowly so that I help Professor Kim to translate my talk. I hope that at the end of the session, we will have an interesting discussion. And I'll be connected throughout if you need my participation. Tell me when you want me to present my slides, and I will carry on with the presentation, Professor Park.
Okay, great. 예, 이제 닥터 페레즈가 본인의 연구에 대해서 간단하게 서머리에서 발표를 해주시겠고요. 이후에 패널 디스커션을 진행하고 이후에 청중 디스커션을 진행하도록 하겠습니다. Okay, Dr. Perez, we will move on to your the summary of the journal and we will go on the discussion with our panelists. Please start.
Sure. So I'm going to talk about one of the papers that has been published this last year, Diseases of Colon Rectum, which I honestly believe it's a very important paper for many reasons, as you will see. I currently work at the Hospital Alemão Oswaldo Cruz in São Paulo, and we are very much interested in organ preservation. So whenever a patient presents a clinical complete response like this, we always consider organ preservation with watch and wait as one of the alternative treatment strategies following chemoradiation completion. However, the nightmare of organ preservation with watch and wait is the development of a local regrowth. Now, the first concept I want to make sure everybody understands is local regrowth is really the reappearance of the same cancer. It's not a new cancer, it's the same cancer growing back again. And if this is true, it really is an incomplete response. Even though we thought it was a complete response, the fact that the tumor is growing back again means that it was really an incomplete response to chemoradiation therapy. That's the first concept. The second concept is perhaps these regrowths, they may actually be worse than the original counterparts. Now, think about it. When we treat patients with chemoradiation therapy, we kill the sensitive cells and we're left with only the resistant cancer cells. Now, in a local regrowth, we are allowing these resistant cancer cells to grow back again to a significant size and volume. So at the end of the day, we may be looking at a regrowth tumor that is actually worse, biologically speaking, than the original counterpart at baseline. Now, when we look at the incidence of local regrowths, you'll see that the majority of local regrowths will happen within the first 3 years of follow-up. And ultimately, 1 out of every 5 or 4 patients who achieve a complete clinical response will have a local regrowth. So it's a quite significant amount of patients within the population who achieve a complete clinical response. Now, in the beginning, we were very much concerned about the salvage of these patients. Local control seemed to be an issue. However, as experience was gathered, we now know that the vast majority of local regrowths can actually be properly salvaged by radical surgery or sometimes even local excision. So at the end of the day, salvage of a local regrowth is not much of a problem. What seems to be the problem within local regrowths is the development of subsequent distant metastases. Now, the first paper who really pointed out to the risk of distant metastases among local regrowths came from the United States at Memorial Sloan Kettering. Here you can see clearly that patients who developed a complete clinical response and then a local regrowth were at a much higher risk for development of subsequent distant metastases. Now, the problem is that these patients were a small number of patients, and we needed more robust information to make sure that the local regrowth was indeed a risk factor for distant metastases. So we looked into the International Watch and Wait database, and you can see here more than 200 local regrowths. And again, local regrowth was the only identifiable risk factor for distant metastases among patients who achieved a complete clinical response and underwent watch and wait. So when you go back to the Memorial Sloan Kettering study, we were a little bit concerned because the comparison of local regrowths in terms of distant metastases to patients who have a complete clinical response but never have a local regrowth is perhaps an unfair comparison. And I say unfair because local regrowths are really incomplete responders, whereas complete responders who never have a local regrowth are true complete responders. So biologically speaking, these patients or these tumors are distinct to start with. So it is probably not fair of a comparison when we compare these two subgroups of patients. So instead of comparing local regrowths to complete responses, we thought that we should compare local regrowths to incomplete responders, since a local regrowth is an incomplete response. So the first idea was to compare to patients with incomplete response managed by radical surgery, by TME. Now, we did a long time ago such a comparison in a retrospective study, and you can see how patients who achieved a complete clinical response and were salvaged at the time of local regrowth had similar disease-free and overall survival to patients with incomplete response managed by TME. So apparently there were no differences in operating on these patients at the time of reassessment or at the time of the development of a local regrowth. As a matter of fact, patients within the OPRA study, a randomized clinical study, showed identical outcomes. You can see here the blue curve refers to patients with incomplete response managed by TME, whereas the red curve refers to patients with local regrowths managed by TME at the time of a local regrowth. And again, no statistically significant difference. But I think that this comparison is also unfair. And I think it's unfair because patients who have local regrowth, they have excellent intermediate response. The intermediate response was so good that we actually mistaken them for a complete clinical response. However, patients who undergo TME, they really have minimal response in the vast majority of patients. And that's the only reason they were never even considered for a watch and wait strategy. So in order to balance these two subgroups of patients, we decided to look for patients with incomplete response, but with a near complete pathological response. Only the excellent responders in an attempt to balance patients with local regrowth who initially achieved a complete clinical response to patients undergoing TME, but again, with also excellent response to chemoradiation therapy. So a near complete pathological response here was defined as less than 10% cancer cells within the resected specimen. So we grouped together our data and the data from the Fundación Champalimau in Portugal and compared to patients who underwent TME at the Bordeaux University from Professor Quentin Denost, who is pictured here. Now, when we did such a comparison, you can see that we looked into 74 patients with local regrowth, 79 patients with local regrowth and 74 patients undergoing radical surgery. And you can see that there are some interesting differences to start with. First of all, patients with local regrowth had earlier stage disease at baseline, which is quite interesting. So patients in local regrowth had earlier stage disease. In addition to that, patients with local regrowth did not receive compulsory adjuvant chemotherapy after they achieved a complete clinical response, as opposed to patients who underwent TME who did receive, in about 1/4 of the cases, adjuvant chemotherapy. So, two interesting differences. However, when we look at the crude rates of distant metastases, patients with local regrowth, despite the fact that had earlier stage disease, did develop almost double the rates of distant metastases. Now, notice the difference in timing of development of distant metastases, which is also quite significant between patients with local regrowth and patients undergoing immediate TME after reassessment of response. So we performed a multivariate analysis to make sure that local regrowth was a risk factor or was an independent risk factor for the development of distant metastasis once patients underwent watch and wait. And you can see here that the only two features that were associated with the risk of development of distant metastasis were final pathological staging and the fact that patients had a local regrowth. So you can see here that these two independent risk factors were quite significant in the risk of development of distant metastasis. Now, when we break these two informations together, you can see that the distant metastasis-free survival is considerably worse for patients with local regrowth. Now, you can see that we have two different distant metastasis-free survival curves. And the one on your left is using time zero, the time of end of radiation therapy. And the second on your right-hand side is a distant metastasis-free survival using time zero at the time of local regrowth. Now, since patients in the blue curve do not have a local regrowth, that's the reason why these curves start with at different time points. It means that the red curve, patients with local regrowth, by the time that they achieved or developed a local regrowth, they already had developed a few distant metastases. So this is an interesting concept. But you can see how clearly the disease, distant metastasis-free survival, regardless of time zero you use, is or considerably lower for patients with local regrowth when compared to patients undergoing TME. Now, this is the most interesting curve of this manuscript, at least from my point of view. And you can see we have broken down patients with local regrowth and final pathological T stage, the two independent risk factors for risk of distant metastasis. And you can see how patients in the purple curve, the lowest distant metastasis-free survival curve, is associated with patients with local regrowth and YPTT3 or 4. So whenever you have a local regrowth and it's a full thickness disease, local regrowth, the risk of distant metastasis is even more significant. So apparently there is an increased risk for distant metastasis among patients with local regrowth, and this risk appears to be maximum among patients who not only have a local regrowth, but also have a local regrowth with a YPT3 or 4 at the resected specimen during salvage therapy. And you can see how this difference is even more significant when we use time zero from the time of local regrowth instead of time zero from the end of radiation therapy. So, in conclusion and in summary, local regrowth seems to be one of the only risk factors for distant metastasis among patients who achieve a complete clinical response after watch and wait. Now, local regrowth seems to be at a higher risk for distant metastasis when compared to near complete pathological responses managed by TME at the time of assessment of response. And this worse distant metastasis-free survival seems to be concentrated and particularly worse when the local regrowth is a full thickness local regrowth, meaning that it's a YPT3 or a YPT4 at the time of salvage therapy. I thank again for the opportunity to speak, and I'll be happy to take any questions. Professor Park, thank you very much.
Thank you, Dr. Perez. We will go ahead to discussion our panelist. 네, 저희 패널 중 강성범 교수님 비디오 켜주시면 감사하겠습니다. 네,
지금
패널
저
디스커션
보이시나요?
후에
저 보이시나요?
지금 찾고 있습니다. 잠깐만요.
목소리는
네, 목소리 잘 들립니다. 네, 저희 패널 디스커션 후에 청중 디스커션을 진행하도록 하겠습니다. 청중 디스커션 때 직접 질문을 해주시면 좋겠지만 좀 미리 질문이 생각나신 경우는 그 챗으로 올려주셔도 좋겠습니다. 네, 제가 강성범 교수님 찾는 동안 패널 디스커션 진행하도록 하겠습니다. 네, 질문 시작해 주십시오. Okay. Do you have any comments or questions for this topic, Dr. Suyong Lee?
Okay, I'm Suyong Lee from Jeonnam National University, Hwasun Hospital. And first of all, thank you very much for writing an excellent paper and introducing its content. 제 질문은 ultimately how to achieve systemic control will be the key issue. And I understand that the watch and wait group did not administer adjuvant chemotherapy at all. And the proportion of TNT was also low, and the induction chemotherapy was not included, right? So my question is, 그래서 제 질문은 인덕션 케모나 혹은 어주번트 케모 등으로 저희가 케모테라피를 했을 때 결과 디스턴트 메타를 줄일 수 있을지를 물어보고 싶습니다. If we administer induction chemotherapy or adjuvant chemotherapy, distant metastasis, could we control distant metastasis much better? What is your opinion?
That's a very good question, Professor Lee. I think that in this particular cohort, the number of patients who received TNT was minimal, and that could have been one of the reasons why patients developed distant metastasis in the regrowth. And ultimately, doing TNT as a routine could actually make these findings disappear in the long run. However, we've done an updated analysis of patients now currently in the International Watch and Wait database. And it seems that the risk of distant metastasis was not affected by the use of TNT. That's number one. The second aspect is we looked into the data of patients within the OPRA trial. The OPRA trial in the United States randomized induction chemotherapy or consolidation chemotherapy. So both groups received a significant amount of systemic chemotherapy. And that study also did watch and wait for patients with a complete clinical response. And surprisingly, the risk of distant metastasis within the OPRA study was very similar to ours, meaning that patients who had a local regrowth had 30% risk of distant metastasis, and patients who underwent radical surgery for a near complete response had 15% distant metastasis. So I'm not sure that the use of TNT will actually decrease the risk of distant metastasis among those patients in the long run. But we will have to see further long-term data from the OPRA study and many other studies who are now implementing TNT as a routine. Just as a reminder, local regrowth takes 2 to 3 years to develop. So since TNT has been recently reported in ASCO 2020 and 22, it will take us a few years to see what the outcomes of patients undergoing TNT and organ preservation will be. But so far, at this point, the risk of distant metastasis have been somewhat disappointing for patients who underwent TNT in our study, in the International Watch and Wait database, and in the OPRA study. But we will have to wait more data to make any definitive conclusions. But I think it's an important aspect.
김영일 교수님 간단하게 서머리해서 답변을 좀 해주시겠어요?
길게 말씀하시겠는데 결국 그 TNT는 지금 이 스터디에서도 크게 디스턴트 메타에 도움이 안 된다고 말씀을 하셨고 그리고 인터내셔널 왓츠 웨이트 데이터베이스 최근 데이터베이스에서도 찾아봤는데도 역시 TNT가 크게 디스턴트 메타에 도움이 안 된다는 것을 발견을 했고 또 오프라 트라이얼에서도 그런 식의 이제 정보를 보여주는 것 같아서 결국은 로컬 리버스가 이제 시간이 좀 더 필요하니까 이제 TNT를 결과를 보려면 좀 더 시간이 필요할 것 같다고 말씀을 하셨습니다.
네. He will interpret your answer in Korean. Okay. 네. 다른 질문이나 코멘트 있으실까요? 김남규 교수님, 오디오가 꺼져 있습니다.
Can you hear me? 잘
네.
들리세요? 네.
네.
우선 페레치 교수님 강의에 감사드리고요. 제가 질문 두 가지만 드리고 싶습니다. 첫 번째 질문은 교수님 강의에 나와 있다시피 이제 워치 앤 웨이트 환자 중에서 로컬 리그로스 했을 때 시점에서부터 컨트롤 그룹과 비교했을 때 디스턴트 메타시스 프리 서바이벌이 상당히 나빠졌는데 그렇다면 로컬 리커런스가 생겼을 때 일단 수술을 살비지 서저리를 바로 하는 게 옳은지 아니면 그때 키모를 먼저 하고 하면 어떨까 하는 그런 질문이고요. 두 번째는 로컬 리그로스의 살비지 서저리 후에 패톨로지컬 T 스테이지에 따라서 이유가 좀 다르다는 결과를 보여주셨는데 제가 궁금한 점은 사실은 시스테믹 리커런스의 또 중요한 리스크 팩터 중에 하나가 노달 메타스타시스인데 셀비지 서저리 후에 노달 메타스타시스에 대한 상태는 데이터에 안 보여주신 것 같습니다. 그래서 혹시 그런 데이터가 있는지 여쭙고 싶습니다.
Okay, I'll interpret it to English. Professor Kim, first of all, thanks for your excellent presentation. The first question is for the patients with local regrowth in watch and wait, compared to the control group, would it be better for those patients to receive salvage operation initially upfront, or would it be better for the patients to receive chemotherapy and then salvage operation? What's your opinion on that?
Thank you, Dr. Kim, for translating, and apologies for the last answer. It was too long for a translation. I'll try to keep it short. I think that's a very good question. But I always, whenever people ask me this question, I return them a question myself. If chemo radiation plus chemo didn't work and the tumor is regrowing back, are we going to use the same chemo to induce treatment or as an induction treatment? Or what kind of chemo are we going to use? So I'm not sure I have a definitive answer here. I think that in the future, I would certainly look for regimens with induction chemo, but we really need to understand what chemo are we going to use, since the chemo that we've recently used did not work entirely well as we expected. I hope this is, I'm not sure what the answer is, but I really I think it's a challenge that we have, and we really have to look at this carefully before we start using whatever chemo to prevent distant metastasis.
Okay, so 일단은 뭐 아직까지 어떤 키모를 쓸지 뭐 도수도 정해지지 않았고 약제도 정해지지 않았다고 말씀하셔서 좀 봐야 될 것 같다고 말씀하셨고, there's one more important question he asked. According to this results, only the YPT stage and the local regrowth is related to distant metastasis, but we all know that the nodal state is very important to distant metastasis, and we're not sure if it's shown in the results here. Can you mention about those?
Thank you. I think it's a very important question as well. Because the numbers of patients in this study was very small, and the number of patients with lymph node metastasis was also very small, I think that the nodose status did not show up as a risk factor for subsequent distant metastasis. And that's one of the reasons we've looked at this again into the International Watch and Wait database. And a new study will come up very shortly with a much larger cohort of patients. And yes, final T stage, final N stage, and the fact that the local regrowth, all three remain as risk factors. And I think that in this study, the reason why end stage, pathological end stage did not show up was simply because of the small sample size.
Alright. 숫자가 적어서 지금 이 연구에서는 좀 유의하게 안 나온 것 같지만, 이제 지금 계속 더 이제 숫자를 키워가지고 보고는 있는데, T 스테이지, N 스테이지, 그리고 로컬 리그로스가 다 관련이 있는 것처럼 나오고 있는 것 같다고 말씀하셨습니다.
토론이 굉장히 깊게 제가 시간을 너무 짧게 짧게 설정을 한 것 같습니다. 시간이 제한적이라서 그 패널뿐 아니라 청중들도 모두 디스커션에 모셔보도록 하겠습니다. Okay, alright, it's a very lively discussion. I think many of you might have some, many questions that this discussion is. This topic is opening up for discussion with the audience either. And please feel free to ask your questions in Korean. 청중께서도 질문 있으시면 자유롭게 질문해 주시면 감사하겠습니다.
일단 질문을 준비하는 동안에 제가 얘기 하나 해도 될까요? 예.
Finally, we have 성범 교수님.
예, 죄송합니다. 지금 시스템이 약간 문제가 있어서 그런데, 우리가 웨이턴시를 하면서 디스턴트 메타를 줄이려고 하는 목적을 갖는다라고 하면, 우리가 아무리 그 웨이턴시 그러니까 케모 라디오 세라피를 하고 나서 리스폰스 평가를 해도 아무리 잘해도 굿 리스폰더에서 3분의 1 정도는 레지얼 튜머가 남거든요. 그러니까 결국 이제 그것이 디스턴트 메타까지 관련이 될 텐데, 그렇게 본다면 디스턴트 메타를 줄이기 위해서 로컬 익시전을 하고 그거에 따라서 추가적인 어떤 TME를 하든 이런 치료를 하는 것이 디스턴트 메타를 줄일 수 있는 방법이 될 수 있을 텐데, 지금 페레스가 어떻게 생각하는지 그거에 대해서 한번 질문해 주시기 바랍니다.
Okay,
교수님.
yeah, Professor Kang asked that if we really wanted to, if our goal is to reduce the distant metastasis after watch and wait, about 1/3 of the patients who receive good response after watch and wait, they experience distant metastasis. And would local excision, doing local excision first for the primary tumor and then looking for a TME afterwards, would this approach help reducing the distant metastasis?
I think that's a very good question, and it's actually a good hypothesis. So I think that two things we have to understand. Number one is if we do local excision here, not necessarily we are decreasing the risk of distant metastasis. It's a good hypothesis, but it needs to be tested. It's not as obvious as it seems. There are many features and there are many biological features that we still don't understand. But I agree with the idea that if we do local excision, maybe we could have prevented a few distant metastases among those patients who would have minimal residual disease. Now remember, not 100% of the local regrowths will have distant metastasis. We are talking about 50% of patients will have a complete response, 30 of those or 25% of those will have a local regrowth, and then 25 or 30% of those will have distant metastasis. So we are suggesting that we're going to do local excision for everyone to really benefit. In 100 patients or 50 patients, we are really going to benefit 3 or 4 patients. So we have to be careful about it, because the ones we don't benefit, or the ones who have significant residual disease, and then we need to do TME, TME after a local excision in the setting of chemoradiation therapy may actually be quite challenging as well. And I'm not even talking about the morbidity of local excision because it has some significant morbidity. But we need to think about those patients who have residual disease, and we need to do TME afterwards. Doing a TME after a local excision seems to be much more challenging than doing a TME at the time of local regrowth. So we need to understand exactly what the cost and benefit is of this idea, but I think it's an idea that needs to be explored in the future. Sorry, Kim, for the long answer.
It's okay. I've been writing it down. 좋은 가설이라고 말씀을 하시긴 했는데, 연구를 좀 더 해봐야 된다고 말씀하시고, 이제 다양한 바이오로직 피처 등 여러 가지 피처가 있기 때문에, 뭐, 그럴 수는 있겠다는 생각은 하지만, 그 로컬 리그로스를 하는 환자들이 다수가 아니고, 뭐, 일부의 환자들이기 때문에, 이런 환자들한테 전부 다 로컬 익시전을 이제, 다 모든 환자들한테 시행을 하는 것이 과연 도움이 될지, 그리고 특히, 이제 이 페레스 선생님 아마 같은 그룹에서 나왔던 논문인 것 같은데, 그걸 언급을 하신 것 같고, 이제 로컬 익시전을 한 다음에 TME를 했을 때가 이제 로컬 익시전 없이 TME를 한 것보다 더 여러 면에서 이제 뭐 R1 리섹션이라든지 뭐 결과가 안 좋다는 논문을 이제 말씀을 하셔가지고 그런 단점에 대해서 언급을 좀 해주셨습니다.
네, 감사합니다. 지금 채팅에도 질문이 많이 올라오고 있는데요. 우선 그 전에 앞서서 청중에서 혹시 질문 있으실까요?
안녕하십니까. 혹시
May I ask a
들리실까요?
question?
Oh, yeah.
Go ahead.
Yes.
Who's the first one? 네, 누가 질문하셨죠?
Go ahead.
Please go ahead. My name is Inicho, but please go
Okay.
ahead, and then I'll ask afterwards.
Okay. And thank you for nice presentation, Dr. Perez. I'm Wonbom Jung from Inje University in Korea. Although study design was a little complex, but I agree with your study design. This result may intimidate the researchers who are insisting strong organ preserving strategy. In your control group, which was the radical surgery group, less than 10% tumor cell, the proportion of YPT3/4 was about 90%. So I think this proportion is a little high. What do you think about this proportion result?
You are correct. The proportion of patients who underwent radical surgery was quite significant, and that could have also influenced outcomes. But when you think about it, ultimately there were no differences in the final T stage between local regrowths and TME. So they were well balanced. What disturbs me the most is the fact that patients in the local regrowth, they had earlier stage disease in the beginning. So I was actually a little surprised that patients with local regrowth with earlier stage in the beginning, similar final pathological stage, still had a more distant metastasis because they had probably at least one reason to have less because they had earlier stage disease. And then they had another reason to have probably similar final distant metastasis because they had similar final pathological staging. But then they have double the rate of distant metastasis. I think it's a little bit concerning. Now, Kim, do you want to translate that or can I go ahead?
Yeah, I fully understand.
Translation, I think.
Okay, so my final point is, and you have to be careful, and I agree with this. There is a limitation to the control group, and I'm sure that Susan is looking at a letter to the editor that has been sent to the journal by Julio Garcia Aguilar, and we are debating on this because the control group is not the best one, and the reason it's not the best one is a proportion of these patients. If we gave more time, some of these patients with near pathological complete response could have achieved a complete pathological response simply by giving more time. maybe they were operated on too early on, and that's the reason there was still cancer there. So actually, we're comparing local regrowths that we know are unsuccessful complete responders to patients who are still ongoing in response, and many of which could have been a complete responder. So there is a risk that a proportion of these patients could have developed a complete clinical response. And I agree, it's not a perfect comparator group, but I think it's the best group that we have available at this point. And this comparison needed to be made to see what was going on in distant metastasis.
김영일 교수님 아주 짧게 요약해서 말씀해 주세요. 시간이 별로 없어서.
네, 뭐 완벽한 컨트롤군이 아니란 건 다들 알고 계실 거라고 생각하고, 하지만 그 차선책이고, 지금 그래도 이제 컨트롤 그룹에서 문제점이 중요하다고 생각하는데, 이게 패솔로직 컴플리트 리스폰스가 나중에 이제 시간이 지나면 올 수도 있었던 환자들이라고 말씀을 하시고, 그렇기 때문에 이제 정확한 이제 비교가 아니라고 말씀하셨습니다.
이슈가 많을 수 있는 문제인 것 같습니다. 저희가 시간이 좀 제한적인데요. 한 분 질문 더 받겠습니다. 아까 질문하시려다 말했던 조은혜 선생님이신가요?
네, 맞습니다.
네.
네, 질문하겠습니다. 네, 안녕하세요. 조은혜입니다. Hello, Dr. Perez. My name is Ine Cho. Thank you for your wonderful presentation and work. I'm still more of a student in the study of surgical oncology, so please excuse me if my questions seem a little too basic. I had two questions. One of them is actually relating to the previous discussion about the control group. I was wondering if you've ever thought about, if I'm not mistaken, as shown in table 1, you showed the clinical stages. I was wondering if you thought of comparing them in terms of YC stages instead of just the clinical stagings, so that we would get a more clear idea of whether they are actually comparable after PCRT. And also my second question was, basically the findings suggest that the T staging after resection resulted in differential prognosis. So I'm sure the results actually shed light back on the importance of detecting local regrowth, because the more advanced the local regrowths are, the worse the outcome is. So I'm wondering if you could share us your thoughts on what you thought of what we could do more in terms of detecting local regrowths. Thank you.
Thank you. I think these are very good questions, and thank you for those. I think that your point is a well-taken one. Ideally, we would have to look at the post-treatment assessment, trying to look for at least comparable group of patients after chemoradiation completion. That's number one. I completely agree with you. Now, the complete clinical responses will show no cancer. That's the reason they underwent watch and wait. So we know what happened to the watch and wait patients. Now, unfortunately, patients who were managed in institutions where watch and wait was not an option did not have that information available. Patients underwent chemoradiation therapy and were usually scheduled an operation afterwards, regardless of what was going in terms of response. But I agree with you that this information would be interesting, and we are currently looking at now at data from institutions that do perform reassessment of response prior to surgery to make sure that these patients have either a complete clinical response or not. Now, my problem will be, as watch and wait is more and more practiced, we will never find patients who have a complete clinical response and undergo straight to surgery, because almost everyone now, at least in some patients, will perform watch and wait. So I think it's one of the challenges that we have. Professor King, you want to translate that, and I'll go for the second question.
Okay, I'll do it very, very shortly. 선생님 당연히 굉장히 동의한다고 말씀하셨고, 하지만 이제 당연한 건데, 이제 왓앤 웨이트 들어간 거는 YC 스테이지가 굉장히 좋은 게 나올 거고, 이제 그 컨트롤 그룹에 있는 거는 YC 스테이지가 이제 안 좋게 나올 거기 때문에 당연히 차이가 날 거라는 말씀하셨고, 하지만 기본적으로 생각은 동의한다고 하셨습니다.
And the second point is also very well taken. And I think there are many words of caution here, Dr. Cho. I think that number one point is we need to be very strict in terms of reassessment of response. That's number one. And when I say very strict, number one of being strict means that we are only considering patients for organ preservation when we have the full scope of assessment tools to assess response, meaning that we have endoscopy, radiology by MR, and digital rectal examination. And this means that the tumors need to be within the reach of the finger to even be considered for watch and wait, because the risk of a local regrowth is so significant, and it's so significant in terms of subsequent distant metastasis. We need to be able to catch these local regrowths very early on. That's number one. Number two, you have to be very careful when suggesting watch and wait or delayed surgery for patients who have near complete response. Because people often think, well, you know, this is a near complete response. It's okay to watch and wait. And then when these patients finally develop a local regrowth, and I struggle with the concept of a local regrowth when a complete clinical response has never been achieved. So you have to be very careful with the near complete responses. And I honestly think that if we start doing strict surveillance, strict selection of patients, and avoiding doing watch and wait to near complete responses, we're going to improve the outcomes among the complete response group and actually benefit the patients who actually are going to benefit the most from this strategy, while preventing them to have this catastrophic outcome of this metastasis. Thank you for those. These are very good questions. Congratulations.
아주
Thank you.
윤열
중요한,
교수님 아주 짧게 해주세요. Very, very short.
네.
Briefly summarize in very short.
내시경 DR이 MR을 사용해서 이렇게 엄격하게 잘 평가를 해야 되고, 왓앤웨이트 환자한테 제시할 때 조심해서 제시하라고 하셨습니다.
네. 사실 채팅에 질문이 많이 올라와 있었는데 저희가 시간 관계상 질문을 다 다루질 못하고 개별적으로 질문해서 Susan, can we extend that time for discussion?
Yes, you can. Mhm.
Okay, thank you. Thank you. 채팅에 있는 질문들이 있는데요. 저희 김영일 교수님 그 질문을 좀 전달해 주시면 감사하겠습니다. 공통적으로 ctDNA에 대한 질문이 있습니다. Dr. Perez, we have some questions on the chat.
There's the questions are somewhat overlapping. They're asking if we can use ctDNA to predict earlier local regrowth or distant metastasis.
I think that's a very good question. And I think ctDNA is coming out as a very interesting tool in the assessment of overall response to treatment in colorectal cancer. Now, the problem in rectal cancer in particular is that when we have a positive ctDNA after treatment, the question is this positive ctDNA from the primary, or is it indicating already occult metastatic disease? It's very difficult to distinguish. And we don't really know whether we should perform surgery or start chemotherapy because there's a risk of distant metastasis going on. So a positive result not necessarily corresponds to the primary cancer. It could reflect ongoing metastatic disease. And that's the problem that we have with ctDNA in assisting decision management of organ preservation. That's number one. And the other way around is when ctDNA is negative, we may still have a microscopic residual disease despite a negative ctDNA result. So we have to be careful how to interpret the positive result and we have to consider the false negative result as well. So I think it's an interesting tool. We're not using it. I mean, it doesn't drive decisions, but I think it adds to the armamentarium of assessment of tumor response. But we're not basing our decision exclusively on ctDNA outcomes.
네.
It's only really last question from the Dr. Yunsol Lee. 김영일 교수님 마지막 질문.
뭐가 또 떴나요, 교수님?
로컬 리그로스를 강화된 추적 검사를 통해서
아.
좀 더 일찍 발견한다면 결과가 달라질 수 있을까요? 라고 질문하셨습니다.
Okay, Professor Lee Yunsuk asked if we do a more strict surveillance to detect local regrowth, like maybe shorten the time, maybe would the results be different?
I think that's a very valid point, and I strongly suggest everyone who is beginning an experience in organ preservation should consider very short interval times within reassessment of responses. If you think about the local regrowth incidence being the highest within the first 3 years of follow-up, we are doing very intensive surveillance assessments within those 3 years. And I'm not sure it will ultimately impact the risk of distant metastasis, but I think there's a chance that we detect local regrowths at an earlier stage. And we think that this may actually help and decrease the risk of subsequent distant metastasis. So yes, I think that's a very valid point, and that is still one of the challenges that we have. Now, reassessments usually mean all 3 studies, meaning radiology, endoscopy, and digital rectal examination. I'm not sure we need so many MRIs during the surveillance period, but I think that digital rectal examination and endoscopy should be very intensively performed within those initial 3 years of follow-up.
네, 감사합니다. 디스커션 굉장히 뜨거운데 시간 관계상 질문은 여기까지 받는 걸로 하겠습니다. 저도 궁금한 게 많은데 저는 뭐 끼어들 수조차도 없는 굉장히 핫 디스커션 굉장히 감사드립니다. That was very dynamic discussion. We will wrap this session up. And thank you for all attendance panelists and Susan. And I especially would like to express my thanks to Young-Il Kim and Maggie for ensuring that all things goes on smoothly today. And before we close, I express my deep gratitude to Dr. Perez. And Dr. Perez, your experience and insights will give is very valuable. It's incredibly valuable and give us very enriched our discussions. Thank you. Thank you again.
Thank you.
And okay. Next, please, Maggie. 네네. I'll announce our next upcoming sessions. 저희는 이제 격월에 한 번씩 매주 화요일 저녁 9시, 서머타임 때문에 저녁 9시에 저널 디스커션 포럼을 진행하도록 하겠습니다. 다음 시간에는 그 웨스턴 뷰에서 본 로보틱 라테럴 펠브 림프노드 다이섹션의 러닝 커브에 대해서 그 교신 저자이신 조지 장을 모시고 디스커션을 진행할 수 있도록 하겠습니다. Okay, we will close this. Dr. Perez, thank you for joining us. We will close this session and have a great rest of the day. 참석해주신 모든 참석자 여러분, 그리고 그 토론에 참여해주신 청중 여러분, 패널 여러분, 통역해주신 김영일 선생님 모두 진심으로 감사드립니다. 덕분에 굉장히 그 열기 있는 성공적인 디스커션이 된 걸로 생각이 됩니다. 모두 행복한 추석 보내시길 바라고 저희는 11월 19일에 다시 뵙도록 하겠습니다. 감사합니다. 감사합니다. Maybe Sunny show winner one screen.
고맙습니다.
Thank you.
감사합니다.
수고하셨습니다.
감사합니다.
수고하셨습니다.
감사합니다.
Thank you.